Hello, and welcome to another edition of Your Therapist Needs Therapy, the podcast where two mental health professionals talk about their mental health journeys and how they navigate mental wellness while working in the mental health field. I'm your host, Jeremy Schumacher, a licensed marriage and family therapist. To support the show, head over to patreon.com/wellnesswithjer, or subscribe, leave us a review on iTunes, all that podcast stuff. Again, I'm a professional therapist, not a professional podcaster. So I'm excited today. I have a guest of a new variety. I have my first psychiatric nurse practitioner. I'm probably screwing up the alphabet soup after your name. But
No, you got it.
I have Rachel Jones of Cup of Tea Psychiatry joining me today. Rachel, thanks for joining me.
Thank you. I'm so excited. I'm nervous all of a sudden.
Oh, don't be nervous.
Okay.
PH,
yes.
PMH. There's too many.
There's too many letters because PNP is pediatric nurse practitioner. So
that was already taken.
So psychiatric mental health nurse practitioner is what they call us. PMHNP.
Yeah.
But I usually just say PsycNP. It's just a little bit easier to say, but
yeah. The nursing community is picky about the PNP already meaning the thing.
Oh yeah, because if I were to say, if I abbreviated my name with that, they would think that I'm working at in pediatric primary care.
Sure.
That's not what I'm doing. So
yeah.
Yeah.
You're my first prescriber I've had on the show.
Wow.
Yeah.
That's so special.
Year 2 of the podcast. I'm getting around to talking about medication. So I always start with the same question, which is, how did you get into the mental health field?
That's a good question. I originally wanted to be a veterinarian, and I was always a super sensitive kid and really wanted to save all the dogs. I still want to save all the dogs.
Sure.
But that was kind of my goal. I was just super empathetic, super sensitive, and had didn't really know anything about psychiatry or the mental health field for a while. Had a brush with it when my brother was sent to troubled teen industry type place when I was in high school, or when he was in high school, I was in middle school. So yeah, it was just not something that I thought about a lot. It was just oh, that's mental health. That's when people, are having significant behavioral issues. That's when they get care for that. And then didn't really think about it much. My family I had sort of a chaotic, I would say financially chaotic family life. Mm-hmm. And my mom lost her house when I was in high school. So I was determined to be financially independent, from a very early age. I was thinking about, okay, when I grow up, how can I be financially okay? So I stumbled into an allied health class thinking I was going to learn about being a veterinarian, but it was really to teach you how to be a nursing assistant. Mm-hmm. So I'm 16 in this allied health class, learning how to change adults' diapers and stuff. Then they bus us over to a nursing home that's down the street, and we are, taking care of people in the nursing home. And that was super eye-opening for me as a teenager. Mm-hmm. I never, had never done that before. I never changed a grown man's diaper before. That was that was a significant developmental experience for me.
Sure.
I remember the first time I was expected to do that. I was just it was dissociating for a second. I was wait, I'm really gonna do this right now.
Yeah.
But I kind of realized I liked helping people.
Mm-hmm.
Not necessarily that aspect was not my favorite with the diapers, but I liked helping people, and I was oh dang, nurses, that's a ticket to middle class. Become a nurse, middle class, boom.
Yeah.
So that's when I decided, okay, I'm gonna be a nurse.
I love this high school developmental thought you had of ticket to middle class.
Yes, yeah, that totally was my mindset. I was oh, perfect. It's fulfilling, and it's stable, and it's useful. I'm gonna do that. Yeah. So I ended up going to I'm from North Carolina, so I went to a college there that had a good nursing program, and then I got this forgiveness loan to go to nursing school. So there's a lot of educational assistance for people who major in nursing. Mm-hmm. So I just had to agree to after becoming a nurse to stay in North Carolina for 4 years, and they would forgive a lot of the mm-hmm. loan. So I ended up going to nursing school, and then a year into nursing school I was I don't like this. So I I ended up going to, like, my first ever clinical rotation in nursing school was in a rehab unit, not like a psychiatric rehab, but like people who just had strokes and like surgeries and stuff.
Yeah.
And I remember thinking, like, wait, the nurses don't have any time to talk to their patients. Like, they're in such a rush, you know, like, they just got to make sure the person doesn't die, give them their meds, and, like, leave the room.
Yeah.
And I was like, oh, no, I do not want to be a nurse. And I saw somebody that was, like, sitting at the bedside of one of the patients, like, with a clipboard. They were, like, talking to them, like, setting goals. It was probably a case manager or something. Mm-hmm. And then I was, like, asking my instructor, like, when do we get to do that? And she's like, you don't get to do that. And I was like, oh, dang. And I was, like, I was in nursing school, like, we had to make these care plans of, like, the priorities for care. And you're supposed to put stuff, like, infection control and, like, preventing blood clots and stuff like that. But I was over there, like, anxiety related to hospitalization. Like, sure. I was just, like, very attuned to, like, the psychological needs.
Yeah.
And then I didn't even know that psychiatric nursing was a thing until my second year of nursing school. And then I was like, thank God. Like, first day of that class, I was like, this is so cool. Yeah. I love this. And then, like, everyone else in the class is like, we hate this. We can't wait for this to be over. I'm like, what? Nobody. So psychiatric nursing, if you don't know, it's the black sheep of nursing. Like, when you're a nursing student, if you say you want to go into psychiatry, most people are like, oh my God, that's so terrible. Like, you're not going to be a real nurse. You know, they just try to convince you not to do it. I don't know. Does anybody, do you guys know that? Like, people outside of nursing?
No.
Yeah.
This is all news to me.
Yeah.
You're my first prescriber on.
Yeah. It's kind of like, I think it's similar in medicine. I think there are some doctors that, you know, they're like, oh, psychiatrists aren't real doctors. So it's kind of the same. Yeah.
I'm familiar with kind of the tribalism in the medical field for sure. Mm-hmm. Doctors and nurses obviously work together a lot, but, like, it's hierarchical in nature, and there's some of that stuff.
So there's totally a hierarchy within nursing.
Nursing.
Yeah.
Sure.
Like, who's a real nurse, you know, like...
That's so weird.
I know. So I had to kind of, like, grapple with that. Because I wanted to... I mean, I've always kind of done my own thing. Like, I didn't, you know, peer pressure was not always, like, that difficult for me to go against. But sure. I think in that context, when I'm, like, just about to graduate nursing school and everyone more experienced than me is saying, don't go into psychiatry, like, you are going to ruin your nursing career, like, you're never going to, like, develop skills that you need, like, you know, I was just like, oh, I don't know, but I eventually decided, like, fuck them, I'm going to go into psychiatry.
So what I mean, I don't need a specific year, but, like, how long ago was this ballpark?
2015.
Okay. So, like, that is almost a decade ago. Like, is that still the case? Because I know from a therapist perspective, like, we're all aware in the field that we do not have enough prescribers. There aren't enough psychiatrists. Like, if you can find an NP who's, like, open and accepting new clients, like, holy shit, like, let's fill that person's caseload for them, because med management is such a pain. Getting people to see a psychiatrist is, like, 18-month wait list. So, like, from a therapy perspective, we're all like, yeah, where are all the prescribers? We need more of them.
Yeah.
So that stigma seems backwards to me, because you would think this would be a good thing, having more people who can go into psychiatry and prescribe.
I think it's changed for the better in a lot of ways. In terms, like, I've met more nursing students now who are, you know, I'll ask them, like, you know, if they go into psych, I'm like, hey, were people supportive of you in your program, or did they tell you not to? And it's like, instead of, like, 100% of them saying, no one supported me, it's maybe like 50% of them are like, no one supported me. You know, so I think there are more people who see the value in psychiatric nursing skills.
Yeah.
But I think as a registered nurse, like, just, you know, bedside nurse, the psychiatric specialty is still pretty unpopular. But becoming a psychiatric nurse practitioner, that is very popular. A lot of people want to do that especially since 2020, when telehealth became the norm and people realized, oh, if I'm a psych NP, I can be an NP that works from home.
Sure.
So some people, wanting to go into it for that reason, or, you know, just a general interest in mental health. I mean, even on social media, and, you know, just our collective awareness. Since 2020, mental health has been much more of a thing. So I think it's more people have realized, like, oh, that's important. Maybe I do want to learn.
You should care about that.
Yeah.
Well, and it's weird. I'm curious. You might not know this off the top of your head. There'd be no reason to, but like we have more therapists leaving the field than going to school for therapy right now. So like the burnout in the mental health field is higher than the rate we're pulling people in.
Yeah.
And like I see the same trend that you're talking about, that mental health is becoming socially more accepted and like culturally we're more aware of it. And there's a discrepancy between like I care about this and like it's accessible to me to go to school for it.
Yeah.
So I think some of the programs, when I worked in higher ed, I coached women's volleyball, and I don't know, 25 out of our 35 kids were probably for nursing. So like I think that's again, like similar to North Carolina, Wisconsin has these tuition reimbursement things and like these ways to get people to go into the field. So I think that's really great. But yeah, I'm curious what it'll look like in a couple of years for that side of things. We need more prescribers, that's for sure.
Yeah. Well, I mean, so we were talking earlier about my Instagram account, Psych Nurse School, which the reason that I created that account in 2020 was actually to try to encourage more nurses, like bedside nurses, to work in psychiatry, because what happens with like people not being interested to work there is the people that end up working on the psych unit, maybe half of them like want to be there and like really care, and the other half are just like, I just didn't want to work in med surg anymore. I didn't want to work in the ICU anymore. And they kind of just, it's not great for the patients, to have nurses there that don't really, aren't passionate about it.
Yeah.
And so I was just like wanting to create, just be sort of something for nurses to see, like, hey, you can go into psychiatric nursing if you're passionate about it, do it. We need you. Don't worry about what other people say. Like, it's it's really great if it's the right thing for you, do it.
Yeah.
And then what I kind of realized is like way more people were interested in my psychiatric nurse practitioner life than they were in like being a psychiatric nurse. Like there's still just like isn't that much interest in being a psychiatric nurse in the hospital setting.
Yeah. That's so weird.
Yeah, I mean, I
don't I have no insight other than like from the therapy mindset of like, I know even in the past, I would say 5 years, like the growth of NPs in the area. And like, again, I'm speaking for Wisconsin. It's where I've been my whole career, but like the NPs in the area has increased a lot. And for therapists who don't prescribe, again, that's been like a blessing to have all of a sudden all these extra people who can prescribe.
Yeah.
So it makes sense to me that this would be a profession that would be of interest, but you're kind of saying from the other medical perspective, like there's a stigma attached to it.
Yeah, totally. And I think another aspect that makes people not want to work like as a nurse, like they'd rather be a nurse practitioner than a nurse, is because the facilities available to work in, it's really hard to find a good one. Like my very first nursing job right out of school was at just a huge like psychiatric hospital chain, like just one of their chains. I didn't know, like as a new nurse, I was just like, oh, this place looks nice. Like it's always like the place that looks really good. They have the fancy website, they have like a really really pretty like pictures on the wall,
they have a good marketing budget.
Yes, and that's what they use it all for. It was pediatric psych, and I was like, yeah, I want to work with kids. And so I start working at this place. And pretty soon I realized that I am the only nurse there that doesn't have, or one of the only nurses there that didn't have restrictions on my license for like, violations. Like, and when I'd been there for 6 months, I was like one of the longest standing employees there, because most people would walk in and then leave because of how bad the working conditions were. But I was kind of stuck as a new grad because I was like had no experience. Like what other job was I going to get?
So this may be a basic question, but again, I think most of my listeners are therapy people. So you have your nursing degree and then you get the psychiatric NP part after, or you did it all at one time, or how does that work? And then I'm curious, like, how does placement work? Are you just like licensed, or is it like you're in training, you need to get hours? Like, what does that look like?
Yeah, well, so there's a few different avenues you can take. I guess I'll kind of walk you through what I did, and then I'll tell you like a couple of the other ways people do it. But so I basically like graduated with my bachelor's of science in nursing, passed the certification to be a registered nurse, had my registered nurse license, and started working in psychiatry because that was the field I was interested in.
Sure.
I worked at that first job, which was like a residential, it was partially acute, partially residential, partially, I don't know, it was just they were trying to do everything there. And I worked there for 8 months, I think, before I was able to leave and go to a better hospital where I also worked in psychiatry, but it was like a way better situation. And then after, I guess like 3 years into being a nurse, I decided to go ahead and apply to Psychiatric Nurse Practitioner program. So I started the program. I did it part-time, so it took me 3 years to complete it because I was also working like as a nurse the other part of the time. And then after, so you can get your master's degree or your doctorate in nursing. I got my master's in nursing, finished that up in 2020, took the PMHNP board exam, and then got licensed as a Psych NP. Like that.
Sure.
So then once you're licensed, depending on the state you're in, some states are independent practice and Psych NPs can just practice without any physician contract or anything. But yeah, some states like Wisconsin is not an independent practice state. So I have to have a contract with a physician that basically just says I will call him if I have questions. And I give him $500 a month, which is a deal. It's a deal because most of them out here charging more than $1,000 a month.
What a scam.
Yeah.
Well, it's because in therapy, it's interesting. And a lot of my therapists who come on have kind of that like experience that you're talking about with this poor working conditions. Therapists get in training license, and then we need to get 1,000 hours of face-to-face time with clients before we're fully licensed on our own. And so many therapists end up working at these homeless shelters, at domestic violence places, at hospitals, at places where you're seeing really high intensity cases. And like those clientele absolutely need therapy. So it's good, but the burnout rate's really high. The turnovers.
You're not getting paid for it.
Or you're getting paid. Like when I started out, and I'm old, so I've been doing this for 15 years, but like I started at a low-fee clinic. This was before Affordable Care Act or anything. So low-fee clinic meant people didn't have insurance, so people were paying $5 or $10 per session, and like, none of that was going to me. And even if it would have $5 or $10, wasn't going to do a whole lot.
It's wild. Like, so for nurse practitioners, like once you graduate and are licensed, like that's pretty much it. Like a lot of nurse practitioners do get like additional training just in their area of interest. But there's not like a required like hours of supervision type thing. That's like in the program, there's like a requirement, certain number of hours for you to get clinical experience. So and then the idea behind the nurse practitioner role, which is no longer being executed very well, the whole reason the nurse practitioner role was created was so that experienced nurses who were experienced in a certain specialty could then become advanced practice nurses in that specialty. So it started out with pediatrics, like in a rural area, experienced pediatric nurses, and there was a pediatrician that was like, hey, I can teach you guys how to do this stuff. So that's kind of how the role started, and then it, expanded. But now I think there used to be a bit more of a requirement for a nurse to have experience in the specialty that they're getting their nurse practitioner degree in, but it seems like there's a lot of programs now that don't really require any they require relevant experience. So I think people kind of say like, oh, I volunteered at this place or whatever, but it's not like they're not like experienced in psychiatry necessarily before they go to the program. Which is like, there's a lot of like debate around that, like within.
I have a friend of mine who's an NP, and I have said, like, if I had known about that as a career path, that's what I would have picked, because she makes way more money than me and spent way less time in school than I did. And, like, lovely human, very talented. Like, I'm not taking any shots or throwing shade at all. Her name's Angel. Angel, you're fantastic at your work. But, like, what she does is what I thought I would be doing. Because I was double major. I thought I would want to be a psychiatrist. And it really wasn't until I got into, like, close to graduating from my college with my bachelor's that I was like, oh, I want to do therapy. Like, psychiatry. Real psychiatry is 15-minute med checks. That sounds awful. Totally. I don't want to do that.
Yeah. And that, I think my experience, like, my first experience in a psychiatric setting at that really horrible facility that I worked at for 8 months, I really, I was, like, 22, and I'm in the facility with these, like, teenagers, like, 17, 18-year-olds, like just a little bit younger than me, all the way down to like really, really little kids. And I'm watching what's going on. This is my introduction to the psychiatric world. And I'm like, okay, so I see most of these are kids in the foster system. Most of them just went through like something really horrific and had some behavioral issue in their foster home, and then they were dropped off here, and now they're being treated with antipsychotics. Like, what? Like, I was just like, this is not right. I really did not sit well with me. It still doesn't. I mean, I left that place crying so many times. What's one thing that sticks out to me is like this boy, I think he was either 4 or had just turned 5. His mom had just died like a week before. And he gets dropped off at the psych hospital because he was throwing tantrums in his foster home, and like they couldn't handle his behavior or whatever. And I'm like, why is he here? And then he's getting prescribed stuff to calm him down. Like, and the thing about that place and places like that, there are lots of psychiatric hospital companies that make a lot of money by just cutting corners for everything involving patient care. And so that first hospital I worked at, the nurse to patient ratio was 1 nurse to 16 patients on a good day. Sometimes it was 1 to 24.
Jeez.
So it was completely impossible to, all I had time to do was give medicine to these kids, and then by the time I was done giving everyone their morning medicine, it was time for the afternoon medicine. And I didn't have any, like, I couldn't do anything, and then there was behavioral emergencies left and right. Staff were walking around with their arms in slings, like black eyes, everything. It was just so poorly run. It ended up getting closed down for violations, thankfully, but it took a few years for it to get closed down.
If it's a giant corporation owning it, they're just gonna go open up somewhere else. It's not.
I was like, how are these people accredited by JCO? Like this big, it's like, how on earth does this place get accredited? It was really confusing. I was like, and it just made me, I just got that exposure to like, okay, these are just like kids who don't have anyone to speak up for them, and they're being pathologized when they're actually having a normal response to a horrible situation, and they're getting antipsychotics. Like we're gonna tranquilize them and then send them back to their great situation. It was really, and so I was like, I started reading this book called by Alan Francis, who was the head of the DSM-5. He has a book called Saving Normal, and it's about like psychiatry over pathologizing things. And so I started reading that book when I was working there, because I was like very like, what even is psychiatry? I really like was like, what am I doing here? But then once I left that facility and I went to like a university hospital that had a really great psychiatric service line, and like 6 different psychiatric specialty units. So like everyone was like I started out in the geriatric psychiatry, so it was just a unit with all these, people with dementia. And I've actually ended up loving working with that population of people. And then they had like a perinatal psychiatry unit. So that was like the first time that I saw like postpartum psychosis, postpartum OCD, like really started to understand like, holy shit, like it's not just postpartum depression, and I'm like 23 and I'm like, I'm never getting pregnant. So then also got to work in an adult crisis stabilization unit. So it was kind of like your general like adult psych unit, mostly for people who did not have psychotic disorders, because we had a separate unit for the psychotic disorders, which was a little more restricted, like because there'd be more like behavior, risk on there. And then at the last couple of years I worked in that hospital, I worked on the child and the adolescent unit and the eating disorder unit. So I kind of rotated between those 3. So that's where I actually got to see like good, I mean, it's obviously there's a lot of issues within psychiatry, but as far as psychiatric hospitals go, that was a good place. Like people there really cared.
And I think obviously the difference between having someone who cares is a big deal, but also having like the right resources for something. Like if you're a place that's just taking anyone and everyone from every place, you're gonna get all these crises that you're not set up to deal with, or not staffed, or not trained. Versus like I went to University of Minnesota, so like 60,000 students, ton of money, one of the few institutions in the country, this might not be true anymore, but it was when I was there, that had as much money coming in from the research they did as their sports programs, which is pretty rare at a D1. But like, again, the difference there of the treatment people are going to get for maybe working with students at a reduced rate, but still like having these super qualified people and just like the resources that are available.
Yeah.
Versus if you're a random person who exists in Milwaukee, Wisconsin, trying to get, like, you're not going to get those resources. No. So like we give that, I don't want to say we give it to, but like, certain people have access to it in certain contexts, and it's really difficult to find it.
Yeah.
Outside of that.
Yeah, definitely. I mean, and I think just what I really learned from like working in those two settings was like, so that first setting with I would have like 24 patients.
Yeah.
The second setting, I would have 4.
Yeah.
So I'd have 4 patients for a shift, and I actually could get to know them, talk to them,
yeah,
like help them, like develop coping skills, solve problems, like that. I was like, okay, this is how like the relationship
right.
that people have and the support they have around them is extremely important. And like, these meds, like for some people they work great and they're super important, but a lot of times you would kind of see where medicine is being called in to fix a social issue, or like a poverty issue, or and it's sad because it's just like, obviously we can't change this system right now, but yeah, so it just kind of, that idea of like you were saying, I don't want to be a psychiatrist, I don't want to do 15-minute med checks. I was like, I'm not freaking doing that either, so when I decided to become a psych NP, I was like, okay, like I'm gonna do this, but I'm gonna do it my way. Like I was just like, I'm not doing it the way, I would be in clinicals during school, and some of my preceptors would be like, oh, you're gonna have to get used to seeing 20 patients a day, and I was just like, no, I'm not. I'm not doing that. Like I'm not doing that.
So fill us in then chronologically, what are the steps then you took to opening your own place? Yeah,
so like right after I graduated as a psych NP, it was 2020. And
hooray, everyone's favorite year.
I ended up working for this really awesome therapist-owned private practice. They employed a couple other psych NPs there too. It was such a great place, but I was working from home because of 2020.
Yeah.
So I was like super isolated, and when you're a new grad psych NP, like you really gotta have support when you have questions and stuff. So I was actually considering going back to being a nurse because I was just like, fuck it, I can't stand working, like being so isolated.
Yeah. What a wild thought. I want to go back to nursing during COVID.
Yeah, I know. Isn't that messed up? Well, also travel nurses were getting paid a lot at that time. Sure. So I was like, maybe I should just do that for a while.
Essential workers. We really treated them well after that ended.
Yeah. So a friend of mine he's from Wisconsin. I had never been to Wisconsin.
Sure.
But he was like, oh, there's this fellowship program there. And I was like, oh, cool. Like, let me check it out. And I ended up getting, like, accepted. And then I was like, I should probably go look at Milwaukee. Never seen it before, before I take this position. So I just, like, flew out, like, fell in love with Milwaukee right away. Like, I think it's such a hidden gem. Did that fellowship program for a year. And then I knew that I didn't want to work for, like, a big corporation or big institution full time because I wanted to have flexibility, like if they start treating me bad that I can go.
Sure.
So I was working where I still currently work part-time at a pediatric clinic that's part of a big institution, and they have great, like, they treat us well, they got great support and stuff. It's still not exactly like my preference for like how I would want to do appointments and stuff, but it's really good compared to a lot of places. And then the other, like, I guess my first year of working there, I took another part-time job at a jail. And I worked at the jail for about 6 months. And then I was like, yeah, just the moral injury of working in there. I was just like, yeah, I can't do this anymore. So that's when I was like, I'm just going to start my own private practice. Like it was really scary to even think about. But I got inspired by like some other people that I saw doing it, and I was like, okay, I can do this. So yeah.
Is that a thing that gets talked about in like your training and your schooling, like if/when you open your own place, or is it kind of
No, yeah, I mean, not when I was in school. Maybe they do now, but
Yeah.
probably not.
Yeah.
It's, they're kind of training you to be, they train you to be in the insurance model. And that's what I'm realizing too, just the more I get into this role and working at different places and then now doing my own thing, I'm like, whoa, so much of my training and things that, ways that people advise you to even just like talk to patients and be with patients is like, how do we conform to the insurance model? Because you got to do that for 21 minutes to use this billing code. And then you got to do this and ask this question to use that billing code. It's like, whoa, like, I don't want to do that anymore.
Yeah.
So, yeah. So it's been really freeing to, I'm very new. I have very few patients right now in my private practice, but it's really cool just that there's so many options for how I can set it up,
Yeah. Well, and I mean, that's a pretty common experience. And again, first prescriber on, but like a lot of the therapists, I try and get therapists who own their own practices on. And like, it is a scary leap. And there's often a delay between building your caseload up to the point where you can just do that. But some therapists, like I was lucky when I left my last private practice, like an agency, all my clients were going to follow me. And so I think I had one who didn't, but it was like everybody followed me. So like starting my own place, I came with a built-in caseload and like that was really nice. Because non-competes aren't enforceable.
Well, and now they're banned.
Yeah, they are banned. They were never really, and it's weird, this is a side topic, but like they were never really enforceable, which I didn't know until I had to hire a lawyer. To get out of to get paid because my last place I resigned and then they fired me and it was really terrible. And we're trying not to pay me, so I had to get a lawyer and he like saw my contract and laughed out loud at it.
Oh my god!
But again, like
they just scare us.
For an employment lawyer, second nature. For little therapist me, who has been taught my entire career, like avoid court at all costs. Court's scary. That seems like, oh dang, I signed like a 12-page contract. That must be really serious.
Well, that's kind of how like nursing culture and nursing education in general is very fear-based. Like from the beginning when you start nursing school, like it's like, you're gonna go to court, you're gonna get sued, you're gonna you're gonna kill someone, and I do get like they do want to, you should have fear when you're prescribing medicines, like you should be aware of how much harm you could do potentially, so I get there being an aspect of fear in the education, but nursing culture really just goes overboard on it, and I think that has made a lot of people feel like, I can't possibly start my own business, or like, how will I do, what will happen when I have to get my own malpractice insurance? It just feels like it's very limiting, the fear can kind of keep you in a box. And then once you step outside of the box, you're like, oh, this actually isn't as complicated as I thought it was. Yeah.
That's so weird. I'm curious. This is a new thought for me. Looking back on it, do you think some of that fear-based training is to like keep you in the profession? And the reason I'm asking, understand, like I'm coming at it from a perspective, like I work with religious trauma, I work with people coming out of cults, and like there's a lot of weird, I would say culty, I wouldn't use the word cult, but like there's a lot of culty stuff in the medical profession from like normalizing your weird fucking work hours and like that kind of badge of honor of like you take all the shitty jobs and like don't complain, and like there's a lot of stuff where it's like we're not learning good boundaries. We're not learning like healthy ways to approach this. You're going into a model that is broken because it's for profit. And then like you're saying like, hey, fear-based training. And I'm just like, oh dang, that's also culty.
Oh my gosh. I'm getting chills right now. Like, no, it's so true too, because I think nurses, I've talked about this a lot with my nurse friends, how, when nurses do try to say, I'm like, I'm going to refuse this patient assignment because it's not appropriate, like it's not safe for this reason, like the staffing isn't right, or, and systematically, like nurses get punished for speaking up for things like that, like patient safety, staffing ratios. It's definitely, they try to prey on the fact that you went into the field because you really care about people. And it's like, what do you mean you're not going to take this patient? Like, don't you care? Like, what do you mean? It's like, they definitely prey on that, like, good. I'm a good person, you
Right.
know?
Or that, like, you're going to take 24 clients because there isn't someone else to do it.
Yeah.
And so,
Well, and that's the thing, because when you're actually there, it's like, okay, what is going to happen if I walk away? Like, I remember in that first job, I was there. I was supposed to have 12 patients that day, and the other nurse was supposed to have 12. The other nurse was an experienced nurse. It was her first day. She walked in, she like saw the situation, and she literally left.
oh no.
And I was just there, and I was like, so these are all my patients. Like, nobody came in to replace her. Like, it was like, okay, if I leave, what's gonna happen? You know, it was just like, when you're in that position, you're like, well, I can't leave them, you know?
Right.
Yeah, it's a really crazy thing.
Well, and it might not be like malicious, like conspiracy theory type stuff, but like I think that's how the system stays intact when we all know like medical care for profit, mental health care for profit is a broken system. Like it cannot work that way.
Yeah.
We do all these things where we're counting on people who care, the bleeding hearts in the profession, to like pick up the slack. And we know hospitals are understaffed. We know psych wards are understaffed. We know like these places don't have the resources they need to be successful. And we're going to try and do what we can within that broken system. And like, I don't know, at some point you just are going to burn out from that.
Yeah, and I think that's what my mission initially was like, I got to get more nurses to work in psychiatry. And then I was like, okay, there's nowhere that is like, there are no good psychiatric hospitals to work at, or there are very few. So I don't want to push people into, because my thought was like, oh, there's so few nurses that care. Like, we need more people that care. And then I'm like, well, no, like, we need to keep people out of the hospital. Like, you know, just whenever we possibly can. Like, it's not always possible, but if there's more outpatient psychiatric providers, like, then hopefully we can keep more people, you know, out of that crisis situation. But.
Yeah. Well, and like I talk about, like, I have clients who go into IOP or PHP, and like those are great, wonderful resources, and we absolutely need to have them as a society. And like, they're not fun. No one does intensive like an IOP stay and like enjoys it.
Yeah.
It then becomes like a like motivating factor to stay out of the hospital in the future, because like that's not a fun experience.
Yeah.
And again, not throwing shade, not saying like people aren't doing good work, just saying like, yeah, that shouldn't be like our line of defense for mental health. That should be like last resort only, not like this is where people who can't afford anything else end up.
Yeah, well, and it's really hard to do. I think what also made me decide to start my own practice was because I just realized, like, no matter, even if I work at a really great place that, like, treats me well and everything, like, if it's a big institution, like, it's going to be hard for me to give the kind of care that I want to give, because I'm not going to have the control over the way that I'm doing it. You know, someone's going to tell me this is how many, you know, for us to keep the doors open, this is how many patients you need to see. You need to use these billing codes. And, you know, it's like, I was just like realizing, like, again, I feel like I had this realization so many times, so I finally acted on it. But like, yeah, it's really hard to provide good care when you work in a broken system. Yeah. And I like appreciate people who do it anyway, you know, because like it's not easy. But yeah, I was like, I will burn out if I keep trying to fix the broken system from within, because it's not working.
Yeah. So let's segue into like what working the way you want to work looks like. Like from your perspective, what does that mean? What does that mean for like what your clients experience and like how you as a provider get to show up? That's
such a great question. And it is like developing as we speak.
Yeah.
So like I guess my current practice, I definitely emphasize like an integrative approach. So it's not, some patients I don't even prescribe medicine. Like it just depends where they're at. Like if they want to take medicine, cool, we'll talk about those options. If they're more interested in exploring like different supplements that might be helpful, you know, like magnesium is kind of the supplement du jour right now, but it is really helpful for a lot of people for sleep, anxiety, like, and if magnesium is going to help you, then great. Like I will recommend you a great magnesium supplement. So things like nutrition wise, and I get like labs, you know, making sure people aren't like deficient in iron, or, you know, things like thyroid issues, things that like could be contributing to their psychiatric symptoms that might not, you know, it's like you could get this fixed. And I don't treat the thyroid issue, but I would say I would find it and be like, this is the problem.
Yeah.
Go over there.
Well, and like thyroid, as again a therapist, like we all know any mental health issue could also be a thyroid issue.
Yeah.
Like the thyroid controls so much of like anything else that's going to show up like a mental health issue.
Yeah.
And again, like from my experience working with that, it's such a pain to get like your regular old doctor or like a hospital type setup to do those tests and run that stuff to like rule it out. So I've been doing therapy for 15 years. I can't remember. I think it maybe in the last like 2 years since I opened my own place, I've had one client who I was really like, this seems like a medical thing. Like you have to go get it checked. You have to get it checked. But like in an ideal setting, we could rule that out all of the time. But like,
Yeah.
I'm not going to wait 6 months. I'm not going to make you not do therapy for 6 months waiting for this test.
Right. Yeah, exactly. So that's part of, I pretty much get labs on like everyone who is open to it. Like if they're having mental health symptoms, I'm like, let's
awesome.
check it out, And then I'd have really long appointment times. So like for an intake appointment, it's like 90 minutes minimum. And then I have like a 2-hour appointment option for more complex stuff to talk about. And then follow-ups are like generally going to be 45 minutes, but they could be, longer or shorter, just depending on what the person needs.
Yeah. Which is, just to put it in frame of reference for people, like for most of my career, I have said, if you can find a prescriber who will spend 25 minutes with you, like keep that person because like you don't get that everywhere. So like 45 minutes is like above and beyond what a lot of people can find just trying to go through their insurance or trying to like find like, hey, this person's connected to the hospital I go to, so I guess I'll go see them. Like, I'm shocked when people get to see a psychiatrist for like more than 5 minutes.
Yeah. I don't do that.
Yeah, which like is such a better model. But.
Yeah, so it's just nice because appointments can be as long as I want, as frequently, as I think, or some of my clients, I'm like, okay, well, we can check in like in a few weeks, and they're like, can I just see you every week? And I'm like, yes, yes, you can, so like I get to make that decision.
Yeah.
So yeah, that's been really nice. Really looking at potential root causes, the integrative approach of like medicines, like it's whatever works. Like if the big pharma medicine is going to be the thing that works the best, we're going to use it.
Yeah.
If the supplement from the third-party tested manufacturer is going to work the best, we're going to use that.
Yeah.
If your new yoga program that you're doing is going to work the best, great.
Yeah.
Like we're going to do whatever works the best.
Yeah.
So yeah, that's my thing. I'm looking into maybe doing like a concierge situation where I can like go to people's houses, especially like elderly people that can't drive and stuff. So there's a lot of things I'm considering right now. But yeah, for right now, it's just like the general, like the fees are what they are. But
and in person or telehealth.
Yeah, in person or telehealth, either one. I really love in person. But telehealth is so convenient for so many people. So
yeah,
Yeah,
I totally get that. I love that model, and I like. My experience with therapists opening their own practice is recent too. Like I've had my own place for 2 years, and before that I was really like disconnected. I didn't know a ton of people who ran their own practice. And so like getting connected in the community is great, but also like I did what a lot of people did, which was post-COVID, be like, yeah, fuck this agency work. Like I'm just going to go do it myself. So hopefully that also happens with prescribers and NPs, because like, again, I think getting to do that sounds so similar to like what I experienced. I don't have to do the DSM anymore. I don't have to go through insurance anymore. Like being able to show up for clients and like not worry that like I only get 8 sessions with them or like a set number of things based on the diagnosis I give, like super freeing. And then like I get to do better work.
Yeah, exactly. Just being able to, that's part of like coming to that realization of like, oh my God, like my whole training has been focused on like what the insurance wants us to do, what is the diagnosis that meets the DSM criteria that I will give this person after talking to them for 30 minutes? Like, what?
Yeah.
So yeah, it's been really great to just not have to immediately pathologize people. Like, that's been really
well, and the insurance model isn't based on like client care.
No.
It's based on profit.
Yeah.
For the insurance company.
Yeah. It's hard because like I'm not dealing with insurance. I'm doing cash pay. I'm like trying to follow the advice of like the people that have done this before me, and like I'm breaking even right now in my practice. But it's hard because there is that like you want to be accessible, and I know I'm not accessible to a lot of people right now, and so I was just talking to the person, my financial advisor. He's basically like he's like so sweet and so understanding with me and I don't understand things about money, but I was like, I want to do like this model where I can like charge less, and he's like, Rachel, that's like, he's like broke it down for me. He's like, that's not gonna work, you know. It's like, I know you want to like be more accessible, but you have to make money first, and then you can look at that. So it's been interesting just going like emotionally going through I don't accept insurance, having people call and you know, say like, oh, like be disappointed that
and it's interesting, right? Because you have this experience working in these terrible places where it's like you're maybe doing good work, but like the environment for the client isn't great or isn't that helpful or is like harmful sometimes. And so like I feel that too, where like I still have those days where I have to turn a client down or somebody like can't keep seeing me because of financial reasons outside of their control, and like it sucks. And like I also remember seeing 25 people, 30 people a week and being miserable and like not making enough to live off of. So it's like that's not great. Like I go back and forth and like there isn't a better option. I know I'm much healthier, like my mental health is much better practicing in a way that's like ethical and genuine and authentic, and I get to do better work.
Yes, exactly. I know it's like I have to keep reminding myself that like if I don't do it this way right now, like where like I'm charging this amount, and, you know, I won't be able to have this practice, and I like, I'll burn out and I'll, so it's just, it's a journey.
Yeah. And it sucks. Like, I mean, being a hippie here for a second, but like, like just existing under capitalism, like it's shitty. Like, for people who want to be accessible and want to help everyone, and like you want to save all the dogs, and you're aware you can.
I do want to save all the dogs. But I love that you do groups. Like I've been trying to think of all these ideas. I'm like, groups can be accessible for people.
I mean, I didn't do groups for like 12 years, so.
Well, you did a group recently, and I was like, yes,
I did a group recently. Great. Well, and like that's part of the reason. Like for me, the podcast is very much about networking because I'm an introvert and awkward, and like. It makes more sense for me in my ADHD brain to like offer somebody like, hey, you can market your stuff through this. Like it's a win-win. And I've really like shifted. I've been doing the podcast for a year to like more people listen to my podcast than I see in a week. And like more people listen to my podcast than I can see in a whole month. Like, so like I'm reaching more people with content that's free. It's not therapy, but like hopefully there's some nuggets of wisdom in here, some things that people can get. And so like for me, like how I've done that, and this isn't a recommendation or like advice, it's just saying like I think a lot of us therapists struggle with that, and whether it's running groups or it's doing retreats or it's, you know, giving back to the community or like volunteering for like teachers or whatever. Like I know some therapists who do specific like pro bono work for first responders or for teachers or whatever. Like a lot of us who are in the field find a way that makes sense for us to like give back. And like again, your practice is new, but my guess is you will get there with like finding that spot where it's like, hey, this is what I'm passionate about, this is what I'm going to do differently, and like that's my way to give back. And like I don't know, you still have those like struggles, but like for the most part I sleep easily at night and not worry about like my rate or that I'm charging too much. Like I've kind of made peace with like like I balance it out on the whole.
That's a good reminder. Like I don't have to do everything right now, you know, like that absolutely is my plan, to figure out a way to like put, you know, just have that balance and be more accessible while also keeping my doors open and keeping myself, you know, mentally healthy. But I don't have to do it all right now.
The point of the podcast, your therapist needs therapy, is to talk about what do you do for your own mental health? What has that journey looked like? What are you doing now to take care of yourself? What does self-care and joy and all of that good, healthy stuff look like in your life?
Okay. So So self-care in our field, like I think we know, it's not a luxury, like it is a necessity. Like we can't do good work if we don't have self-care. And I have struggled to figure out what that looks like for me. I've tried a lot of things. But I think what I've learned about myself, just being extremely extroverted, is like I do get very like re-energized and refreshed by being around people that you know, I can just hang out with friends, or especially like colleagues, like people who get it, you know. And so I definitely make it a priority to have like to meet with friends or like do stuff on the network, which is like my little membership thing for Psych NPs. So I do a lot of that, which is very fulfilling for me. And then I definitely love to get like facials. That's one of the things that I do.
Yeah, a little
to
spa,
take care of
little spa
myself.
day.
Yeah, I have this girl that does my facials, and she's so sweet. And it's like once a month I go and do that, and so that helps me feel like I'm taking care of myself. Big dog person, obviously, want to save them all, but I have 2 dogs at home, so just spending time with them.
Yeah.
Also, my partner Dan is a musician, and so it's nice to have a partner who does something totally different than me.
Yes.
And so I often get to go to like cool shows, like, for
Yeah.
free, and just be on the list.
Yeah.
So that's a really fun part of my life too.
Shout out to Dan and all musicians, but let's go back to talking about dogs. Because you said you have a Chihuahua mix.
Oh yeah. So okay.
So you have 2 dogs.
Yeah, the second dog is a very new addition because my neighbor passed away a few months ago, and he had a dog, which I did not know that he had a dog until his tenant, who had like just ran into Dan in the alleyway, was like, "Oh yeah, I've been taking care of this dog, and I can't keep him anymore because like he works a lot. I mean, he did his best taking care of this little dog for as long as he could, but he's like, I'm gonna have to bring him to the shelter." And then I was like, no.
Can't save all the dogs, but you could save
I
this dog.
I could save this one. So I like hadn't even met him yet, didn't even see him. I was just like, we'll take him. Bring him over.
So you have 2 little dogs?
Yeah. He's like probably 10 pounds. My other dog's like 25 pounds.
Yeah.
So they've gotten along pretty well, better than I thought it was gonna go. Right. They're not like best friends, but they're doing pretty good. So.
Yeah. I have a long-haired Chihuahua, and then we had 2 Great Dane. We had 2 Great Dane mixes. So we have 2 big dogs. One passed away last summer. So we have 1 big dog, just like 110 pounds, and we have 1 long-haired Chihuahua.
What is the Chihuahua personality?
So his name's Baskerville, named after the Hound of the Baskervilles, Sherlock Holmes. So we named him after a hellhound, which was maybe a mistake on our part. But when we first got him, he was the only dog we had. He wasn't fixed yet, and like he was a gem. Yeah. He loved animals. He humped other animals, but like whatever. So then we were gonna adopt our next dog. We had to get him fixed, and like after he was fixed, he was all of the like classic Chihuahua traits.
No way.
Like yippee and like
territorial.
So getting fixed did the opposite for him for whatever reason.
That's wild.
Yeah. But at that time when we adopted our first Great Dane mix, he was the best dog ever. And so he helped mellow our Chihuahua out a little bit. Yeah. And unfortunately, that was the one who passed away. So now we have 2, a big dog and a little dog who are both kind of anxious all of the time. But yeah, it's good.
Yeah, it's been, I grew up with a lot of dogs, and they were always big dogs, never had any small dogs. So I never thought I was going to have small dogs. But when I got my first dog, like she's 8 years old now. I got her when she was like 3 months old. Mm-hmm. I thought she was a basset hound mix of some kind, so I thought she was gonna be like kind of big, but she just stopped growing. She just stopped growing at 20 pounds, and I was like, all right, well. And then we got this little Chihuahua guy, and I'm like, all right, I'm a little dog person.
Little dog person.
Could not have predicted.
Yeah.
I would like to have a dog that could be a therapy dog that I could take to work, but neither of them have the personality for it.
That's on my agenda too. I keep doing trainings and getting new certifications instead of doing the therapy dog thing. But I think our Chihuahua is 12 and our Great Dane mix is 10. So they're both old. We're not like I'm saying I'm waiting for them to die, but like we have 2 little kids, 2 dogs, like adding a puppy seems like a lot right now. Yeah. But it is on my list to have. I just want a purebred Great Dane. I'm a big shelter fan, and like it hurts me to say I want a purebred, but I've always wanted a Great Dane.
Yeah.
So.
Yeah, I love Great Danes. They're so gentle.
Yeah, that gentle giant.
Mm-hmm. And that would be such a good therapy dog.
Yeah.
Love that.
He could just have like his own. It's on my office podcast, so I can't show my office. But I have 2 large couches and my chair, so like Great Dane could just have his own couch.
Oh, yeah.
Or her.
How do you have to like? I guess any dog could be a therapy dog if it has the right temperament. Right?
Yeah. Our big dog Isengard, Izzy, he loved everyone. Our vet offered to adopt him because he liked going to the vet, and our vet's like, this doesn't happen.
That's
and he was just like, he loved everybody. Like we joked, we take him to the dog park and he'd try and go home with like every family. Like he loves us, but also like he will take a new family any day. So he was the best, and he was So there are different levels. So he was good canine certified, which means like not at that therapy dog yet, but like certified enough where we could have taken him places, and he has a little vest and stuff. So that next level of training would have been for like a therapy dog. Okay. So
but I guess
some levels for training.
You could, if you have your own practice, you could just bring him to work.
Yeah.
Right.
I think there's probably some, well, ignoring the ethics or morals of saying this is a therapy dog when it's not. I think there's probably some liability if it's not.
Right. Yeah.
I don't know. I haven't looked into it because I don't have one yet.
The first practice I worked for, the therapist-owned one,
just brought it in every
on
day.
their website, it just said like, we bring our dogs to work, so if that's a problem, then we're probably not the right practice for you.
Yeah.
And everyone just brought their dog to work.
It's honestly like, this sounds bad. It's a nice like thing because we have an office dog here. He's not a therapy dog, but the owners who I lease from, they bring their dogs to work every day, and he's like medium sized. He's very sweet. But like it's a tell for me if clients are like, oh yeah, we're not dog people. I'm like, I'm not sure if we're gonna be a good fit in therapy. But I have one person who's allergic, and like it really is sad because they would like to do in-person therapy, and so we do virtual, which is fine. Again, that's nice to have the option, but like it's a bummer because I don't think about that. I get it with my allergies sucking today for outdoor reasons, not dog reasons. I was like, yeah, it's not worth it. But
yeah, dang.
Yeah, Great Danes are short haired, so like fewer allergies, fewer issues with hair.
Yeah, I mean, I'm allergic to dogs, but I can't. I can't let that run my life. Yeah. But I'm also not allergic enough to, like obviously I can live with them and be fine. I'm sure some people have way worse allergies, but
love the dogs for the mental health, and they get it. So you do a bunch of stuff. You're all over the internet with lots of options. You hinted at a membership thing. You talked about your Instagram. So now's the time to promote it all. Where do people find you if they want to connect or they're interested in more of your work? Where do they go to find you?
My private practice website, www.cupofteapsych.com. And I'm also on Psychology Today and stuff. My Instagram account, I have a couple of Instagram accounts. The one that I probably post on the most is it's Psych Nurse School, so psych.nurse.school. That was the one I created in 2020, and it's pretty hopping over there. And then I have a Cup of Tea Psychiatry Instagram, but I don't really do that much on it yet, but hopefully I will soon.
Hopefully that will get busy as well.
And then my friend Lindsay and I actually just started a membership thing for psychiatric nurse practitioners. We actually based it off of the Therapist Network. I don't know if you know about the Therapist Network on Mighty Networks. Mm-hmm. So I found out about the Therapist Network, and I was like, that's so amazing. We need that for Psych NPs. So we made the Psych NP Network. So you can go to psychnpnetwork.org and you can check that out. Or if you have any Psych NP friends who need friends, they can join.
Like community building, support.
We do case consults on there every week, and it's really nice because a lot of places where Psych NPs work, like especially if you're new in the field, there's not a lot of support and stuff. So we wanted to sort of have a place to create that. So I think those are all my online projects.
Yeah, and we'll have all that stuff linked in the show notes, so it's easy for people to find, and they can just follow the link.
Yeah.
Rachel, thanks so much for coming on today.
Thank you for having me.
Yeah, it was really great. And to all our wonderful listeners out there, thanks for tuning in again this week. We'll be back next week with another new episode. Take care, everyone.